Our final speaker for this session is Dr. John Salsman. Dr. Salsman is a professor in the Department of Social Sciences and Health Policy at the Wake Forest University School of Medicine. And he's the director of clinical research in the adolescent and young adult oncology, and also the co-leader of the Cancer Prevention and Control Program at the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. Dr. Salsman is a clinical health psychologist by training, and his work focuses on maximizing the health-related quality of life of AYAs with cancer, both during and after treatment. So please help me welcome Dr. Salsman.
Okay, so I have that unenviable task of being between you all and your lunch, and we're behind schedule, right? So let me see how quickly I can go through this. First of all, thank you for the invitation to be here, and it's such an honor to be with such a rock star panel. So you all have done such a fantastic job. I really have nothing to disclose other than the fact that occasionally I will read spam email for the pure entertainment value. As academics, you know, we get all these invitations to do different things and they try to puff you up as much as possible. So I had this one recently. We'd like to inform you that research.com, don't go there, but research.com, a leading academic platform, has just released the 2023 edition of our ranking of best scientists in the field of social sciences and humanities. Okay, I was intrigued, right? I'm like, okay, best scientist. Maybe they got me top 100. Can I dare to dream? Top 50, top 25. I'm sure you'll be very happy. You're number 2,654th in the US and number 5,388th in the world. Don't put that on Twitter. So with that bar sufficiently low, I would like to say that I want to touch on about 5 different things very briefly. You've heard this at different times throughout this presentation, but when we talk about the unique needs of AYAs and we think about the patient experience, we really have to think about what that's like for a 15 to 39-year-old in general. It's hard to be at those ages in general. We'll talk about specific needs. I'll highlight some key priorities that will dovetail nicely with the comments that have already been shared today, highlight a few gaps, and then touch base. It certainly won't be exhaustive by any stretch, but touch base on a few things about what can we do. So first of all, for life stage, one of my, as David mentioned, as Dr. Freyer mentioned, I'm a clinical health psychologist by training, and early in my work, I had the fortune of being able to be part of a cancer patient support program funded by philanthropy, like many of those are, and we could provide free psychosocial support for patients. One patient in particular stuck out to me. She was a young adult who was newly diagnosed with cancer, was at that intersection of her life when so many things were going right when she got diagnosed. And when we did the triage and I talked with her, she said, I don't want any ribbons. I don't want any support groups. I don't want any books. I just want to rip this chapter out of my life. And it's such a telling and poignant example that's consistent with a lot of patients during these ages. It's adolescent and young adult oncology at its core should be a time of becoming, a time of celebrating many major life milestones. Unfortunately, for many young adults, it has the scarlet letter type of effect. When I've been part of town halls before, one of the pediatric oncologists often says, welcome to the club you never wanted to be a part of. And so for these young adults, that diagnosis has significant ripple effects. It leads to delays, it leads to disruptions on all of these important areas of their life. And when we think about adolescents and young adults, as Dr. Freyer pointed out, there's a lot of developmental heterogeneity in that group. So the types of issues and the types of concerns are going to be a little bit more some concerns will be a little bit more salient for those young adults who already have established relationships and new jobs and maybe are a little bit more financially secure than those emerging adults who are still trying to find their way versus those pediatric patients, those what we could sometimes call late adolescents who are starting to figure things out but are still buffered and insulated, hopefully, by their parents. So what are the types of needs? We've heard a lot of language around the unique needs of AYAs. And I had some pushback when I was talking with an oncologist friend one time about this, and he said, well, what are those unique needs? Because all the all the needs that we bring up are needs that other patients experience too. And so when I thought about it, I thought, well, is it so much that they're unique, or is it about the acuity and the fact that there's so many things happening at once? We saw in Ben's presentation, he referenced Dr. Ng's work in Lancet Oncology. Here's this conceptual model where she highlighted a lot of the key psychosocial considerations for early onset colorectal cancer. So there are a lot of things going on, and it's very rare that a young patient will present with just one of these. Often young patients have multiple areas that are impacted, and often they're at high acuities. So it takes, we've talked a lot about the strength of the multidisciplinary team. It often takes a lot of buy-in, a lot of good team-based support to make this happen well. So in the next 2 hours, I'll be talking about trying to synthesize this in a little bit more cohesive fashion. Now, this doesn't really synthesize. This is a wonderfully elegant model by Dr. Larissa Nekludoff from Dana-Farber and Brigham and Women's Hospital, this quality care survivorship framework that she developed, and now the NCI Office of Cancer Survivorship has adopted and adapted this model themselves. And it's this great multi-level framework that highlights the key considerations. For me, I want to focus just on the psychosocial effects, and these three in particular. You've already heard us mention them so far, but psychologically, what are the key issues? From a financial perspective, what are they? And also from an interpersonal or social, what are those? Psychologically, we know that AYAs in general experience a high level of cancer-specific distress compared to older adults with cancer. Similarly, fear of recurrence, 31 to 85% of those experience that, again, in comparison to older adults with cancer. Similarly, high levels of depression and anxiety. We heard from Dr. Yu, scanxiety, that term for many AYAs who experience fear of recurrence. It gets triggered, understandably so, whenever they come in for scans. And the interesting thing about anxiety, as we saw from Dr. Blaes's data, is it doesn't just stop when they're done. It continues throughout the post-treatment survivorship phase. So it's something that we need to be continually mindful of, and we need to continue to monitor. From a financial perspective, we've heard the term financial toxicity often talked about within the context of treatment. But the interesting thing is, from qualitative data that I have with AYAs, when they're on treatment, they typically don't talk a lot about the financial hardship. The financial hardship becomes more of a salient issue during the post-treatment phase, when the bills start coming in, or maybe when they're trying to return to work, but because of complications or late effects, they're having some challenges there. So those concerns start to emerge more often during the post-treatment survivorship phase. And when we think about financial hardship more broadly, we often think about three dimensions of that: the material, the psychological, and the behavioral. So the material is the resources that patients have, the psychological, how they feel about what they have, whether they're distressed by that or not. And often we catch that during distress screening initiatives within clinics. And then the behavioral, what they do as a result of that. The behavioral can be particularly problematic because if our young adults are trying to make a decision between filling a prescription medication versus getting food on the table or paying their utility bills, right, that can impact their outcomes. Now, from an interpersonal perspective, some of you all may have seen this come out, the Surgeon General's report earlier this year. He referred to the epidemic of loneliness and isolation. And he said our relationships are a source of healing and well-being hiding in plain sight, one that can help us live healthier, more fulfilled, and more productive lives. Now, this isn't AYA specific, but we know if this is the background, this is the context for our population in general. You think about the challenges for an AYA overlaid on top of that, and you think about the challenges of a cancer survivor. That has, again, significant ripple effects on intimacy, isolation, experiences of loneliness. That can also impact, we heard from Dr. Blaes's presentation, body image, fertility, sexual function. So there are a host of issues, and in each of these three areas, psychological, financial, and interpersonal, These are honestly what seem to be the big three, because this is where we have clinically significant levels of disruption that can impact care, that can impact outcomes. So that data was more from a big picture of AYAs in general. Why do we know if we just focus on GI or early onset colorectal cancer? Well, as with other areas, we don't know as much, but this review from a group out of New Zealand came out earlier this year. And what they did was, as with any systematic reviews, they surveyed the research literature, narrowed it down based upon their inclusion-exclusion criteria. What they found from over 5,000 patients with early onset colorectal cancer, they identified 15 studies, so only 15 studies from this group. That's the bad news, if you will, because we don't know that much. The good news is, in terms of study quality, these were good studies with low risk of bias based on the criteria they applied. And they were focused on overall quality of life and domain-specific quality of life, domains across each of these three areas that I talked about. What they found is the psychosocial needs of colorectal cancer are poorly investigated in early onset colorectal cancer. Overall, literature is inconclusive. However, there's some evidence that global quality of life alongside psychosocial impacts related to career, finances, relationship, emotional well-being, and social well-being, family well-being is disproportionately affected in early onset colorectal cancer patients compared to late onset colorectal cancer patients. So again, kind of what we're seeing from these other strands, not surprising, but helps move the needle maybe a little bit. One of the disappointing things when I looked at the studies they had, of those 15 studies, only 2 were longitudinal. So vast majority cross-sectional. And this was a review done earlier this year. So it was refreshing, Dr. Yu, to see some of the data that you were presenting that had longitudinal outcomes, to see that PRO data that Dr. Corrigan had presented and others. Now, where are the gaps? I already alluded to one of those. Dr. Freyer mentioned this early when he talked about who we're missing with our patients. Sometimes, if not often, the zip code can be more important than the genetic code. So if our AYAs, if the representation in our samples are the white non-Hispanic patients, well-resourced patients, we're missing some important groups that we need to better understand to help those who are most at risk improve those outcomes. So we need to be thinking about where people play, where they pray, where they work, and where they live, and make sure that we're intentional about including them in our data samples. We need to make sure that we have good representation by race and ethnicity, by sexual and gender minorities, and by rurality, among other areas. Secondly, I already mentioned we have so few longitudinal prospective studies. This was from a group, a Canadian group that just reported these data. Their data were not limited to gastrointestinal cancers. It was much broader than that, but I pulled out just the early onset GI group. This was the ESAS, so it's a quick and dirty Edmonton Symptom Assessment Scale, single item, Likert scale response for each of these. Prospective repeated measures assessment over the course of a year. So interesting, perhaps doesn't move the needle as much as we would hope, but these types of things and more are areas where we need to go as it relates to cohort studies. We mentioned this yesterday during the think tank. Certainly a lot of the AYA research is done in comprehensive cancer centers, NCI designated cancer centers, that it's helpful to move the needle forward. It's helpful to get that data in, and yet where do most of our patients receive their care? Most of our patients receive their care in community-based settings. How can we leverage the NCI community oncology research practice? How can we navigate the challenges of leveraging INCORE, but where are the potential for leveraging that to advance knowledge because it gives us access to more representative samples? Okay, yesterday, Dr. Marshall said, I'm tired of hearing about we need more research, we need more research, we need more research. So some of y'all are laughing, so I guess he says that a lot, right? So what can we do about that? Again, this is not exhaustive, but if I was to design a study now to try to target each of those 3 areas, where would I start for interventions? Where are the interventions where I feel like the evidence is the strongest, the most robust, or the early data seem to be most compelling. So, I skipped a slide already. In the colorectal cancer space, as I mentioned, there's not a lot. I did a quick search, quick and dirty search of clinicaltrials.gov, early-onset GI cancer, psychosocial interventions. There were 3 that were listed there. The first one, Dr. Kelleher, is at Duke Cancer Institute. This is mHealth symptom management intervention, so digital health to look at cognitive behavioral coping skills, and with primary outcomes of pain, fatigue, and distress to see if she can move the needle, reduce the reporting of each of those over time. Second study by investigators at Cedars-Sinai is a single-arm physical activity intervention, remotely delivered. Results are in, but not reported. Sorry, study has closed, but results are not reported in clinicaltrials.gov for that one. First one, study is actively recruiting. Third is not colorectal cancer specific, but it hit in my search because they have a subgroup of colorectal cancer patients. Scott Baker, as many of you know, is at Fred Hutch, digital resource in the AYA survivorship space to get AYAs connected to resources that might be most helpful to them, randomizing them to those resources, I believe, versus standard of care. So where would I start, though, if I wanted to use the most evidence-based intervention? For psychological interventions, I would do a resilience intervention developed by Dr. Abby Rosenberg, who's currently at Boston Children's. When she developed this, she was at Seattle Children's. PRISM is an acronym for Promoting Resilience and Stress Management. It's a brief skills-based coaching, so it's navigator-led intervention targeting 4 resilience resources: stress management, goal setting, cognitive reframing, and meaning making. What we see in the research literature is there's no one size fits all to help AYAs. Because of the diverse needs that they have, having multiple skills, almost like a buffet style approach to skills development, can be enormously helpful for them. This was data that was reported in JAMA Open a couple of years ago that showed the durability of these effects, in particular, the durability of hope for patients. Let that sink in for a little bit. The durability of hope as a result of this intervention over the course of 2 years, as well as some nice movement on resilience, distress, and quality of life. What about for financial hardship? Dr. Ann Kirchhoff at Huntsman in Utah is doing some really nice work in the health insurance literacy space. We said this yesterday during the think tank that a lot of AYAs don't know what they don't know. So they don't know where to start. And so for health insurance literacy, helping them better understand their health insurance, giving them the skills, and then honestly, we think we need to take this a step further, but do some patient navigation after that can be a way to yield benefits. And I don't have this reported here, but she's reported some early preliminary efficacy data at ASCO Quality. Lastly, for social interpersonal interventions. These are not interventions per se, but you all know how enormously helpful it is and essential to be part of a community. And so for AYAs, when they're in that cancer center, especially if they're in the adult setting, as many of the early onset GI cancers will, they look around the room, they don't see anybody that looks like them. They want somebody that's been in their shoes. Colorectal Cancer Alliance, Merman Angels can help provide that one-on-one support. And then for broader community-based support, virtual meetups, virtual support, each of these institutions, each of these nonprofits have a wealth of resources for our AYAs to help them feel less alone, to help them feel more connected, to help engender some of that hope. So many of you all know Allison Rosen, and she was on Dr. Yu's slide. She's a patient advocate out of MD Anderson. She works with the American Cancer Society now. If you all saw the ASCO post earlier this week, there was a nice feature in there about her. I started my presentation talking about a young adult who wanted to rip out this chapter in her life. What if we could help our AYAs write new stories? And Allison is doing that. The life I envisioned before cancer is very different from the life I'm now living, but it's a small price to pay for being alive. I was sure by now I'd be married and have several children and a career in forensic science. Cancer has given me a new perspective on life. It's made me realize how precious and fragile life is. Rather than lament what I don't have, I'm grateful for everything I do have: a wonderful family and friends, a career with the ACS as director of Project ECHO, good health, and new life purpose to help bridge the gap between the healthcare system and and the communities it serves. So in many ways, isn't that what we want for our patients, right? Is to help them live rich, full lives, to help them write better stories. Thank you. Yes, so sorry, I'm so used to saying for those of you that are on the call that might not have heard the question, but they probably heard the question, right? Okay, in terms of resources for cancer, for caregivers of AYA survivors, yes, a number of those organizations that I mentioned do have caregiver-specific programming. I didn't list them on the slide. True North Treks, for example, is a group that helps focus on AYAs to find direction through connection. Takes AYAs out on week-long wilderness treks. They have caregiver treks that are part of that. Of course, I know that's maybe a little bit more than perhaps what you were thinking about, but yes, there are a number of those resources available, and I'm happy we can touch base offline if you.
I'll ask one sort of big picture question. Pediatrician leading the way, we had sort of adult clinicians, on side. We have the parameters in this group. 15 to 39 has always felt awkward. You know, do you want to be in a clinic with graphs on the wall, or and then, but is the 25-year-old or the 35-year-old more in common with the 50-year-old than they do with the 15? So do we need a new basket of patients?
I've been talking too much.
We can both say something. You know, I think there's been a lot of debate about this, obviously. I think that the consensus that I hear in national meetings when they're talking about what that upper age limit should be, it depends on what the issue is. Depends on what you're, talking about. If it's an epidemiology issue, it's important to define the age group. Somewhere broadly, though, concept when this was developed was that there are enough differences in different domains of, what their baseline health is, what their developmental stage is, what their, tasks are that face them, that distinguish, broadly speaking, that age group between, in comparison to very young children who are still under the care of their parents, and then older adults who have largely navigated all of those challenges. So I think I think the age depends a little bit on what the issue is that's being discussed.
Add to that, I think one of the common themes that have come up in a couple of them is almost more the concierge or like a checklist. So, ASCO came up with this checklist for adolescent and young adults. I think, Nancy, you talked about in your program sort of this list of services as well, because they may have different needs, your 20-year-old versus your 30-year-old. But you also, in an adult practice, especially knowing many of them are seen in community practices, it's almost like you need to meet the patient at the right time with the right service. And that can vary for people depending on where they're at in their life stage. Some programs are looking at whether that's an RN care coordinator, like a survivorship nurse. Is that a health coach of some sort to connect patients to those services? So I don't know that it needs to be in a different space. I think we can utilize models we have, recognizing that we do need sort of this array to try to meet patients at the right time.